Hello, so we are going to discuss respiratory problems in adults. So first we're going to talk a little bit about the anatomy of the nose. You can see you've got your your nares, basically your nostrils. There's your turbinates. You've got frontal sinuses up here. These are the sinuses that are air filled, but when they do get filled up with gunk, like mucus, whatever, that's what causes people to have that sinus pressure, and they can get infected and become a sinus infection. A lot of times you'll know that if somebody like leans down, leans forward, and they just feel their head hurting, sometimes their teeth hurt. Those are all signs of a sinus infection. An upper airway obstruction, it's basically if there's any kind of interruption in the airflow through the nose, mouth, pharynx, or larynx. It can be life-threatening, and it's essential to recognize that early. Could be some tongue edema or an occlusion. So what are two things that should come to mind? Occlusion, you could think about choking. Tongue edema, think about anaphylactic shock, right? So you'd want to assess, you could see if there's a partial or complete obstruction. You would notice somebody would become very diaphoretic, tachycardic, they would have anxiety, elevated blood pressure. They would become hypoxic. First thing you need to do is determine the cause, and suction if possible. May have to do abdominal thrusts for the foreign body. May have to do a tracheotomy or intubation. Obstructive sleep apnea. This is, it's an obstruction, either the soft palate or tongue. A lot of times it's when people sleep, and especially if they're large, obese, overweight, things soften the soft palate, and it just, everything kind of relaxes and drops, and it blocks the airway. Or a large uvula. That's the little thing that hangs down the back of your throat, the little uvula. That could be very large. A short neck. Smoking, large tonsils or adenoids. Often what they do is, the CPAP, which would force the air in, but also for severe cases, they can do surgery. I've had a friend that had, wow, and this was pretty crazy, but he had his uvula removed, he had his tongue shaved down, he had his tonsils and adenoids removed, all at one time. The guy said he thought he was going to die. He said it was horribly painful, most horrible thing he's ever gone through, and then it didn't even stop. So he still continued to have sleep apnea, so it was all for nothing. Men are affected more than women. Doing an assessment, of course, you want to do the history, you want to look at their height, weight, look at their neck. Typically, you can look at, even if they're overweight. Irritability, depression, because they're not sleeping at night. Often they don't realize they're not sleeping. They wake up briefly, but they don't wake up enough to realize they're awake, so they're not getting a good night's sleep. Sleep study, and it's interesting because it used to be people would go to a sleep clinic for their sleep study, but now they're even doing them at home. You can have all kinds of, with obstructive sleep apnea, you can have cardiovascular issues, metabolic issues. My brother has AFib, and where did AFib come from? Who knows? Well, what they've determined is it came from sleep apnea, and he is overweight, and it caused him to go into AFib. So with the plan for someone with sleep apnea is you want to improve their sleep. You have your non-surgical managements, which we talked about that, changes in sleeping positions, weight loss, the CPAP. Surgical, we talked about that. There's the CPAP right there. There's different ones. Some of them they had really big masks. Now they even have the smaller, like these nasal cannulas now, so it's not as claustrophobic. They even have one that's internal. It's placed surgically. I don't know how I feel about that, but I don't know anyone that's had it done, but it is out there. Education, that's the biggest thing. Education, you need to let people know that if they do not wear their CPAP, they could stop breathing in their sleep and not begin breathing again. And people do die from that. So again, evaluating their outcomes, that is when they're actually having improved sleep, that they're feeling better during the day, more energy, fewer sleep time apnea periods, 10 seconds or longer. All right, epistaxis. What is this? Epistaxis. It's a bloody nose, right? Could be from trauma. You get punched in the nose. Being playing ball. I had that happen when I was a kid, but playing basketball and the basketball hit me in the nose. I had a bloody nose. Could be hypertension. Sometimes it occurs after sneezing or blowing the nose. Often they want to pack the nasal cavity. Sometimes you may have to even have it cauterized. Posterior nasal bleeding is an emergency. You want to make sure you assess for any type of respiratory distress. And when the tubes or the packing's removed, you want to use some like petroleum jelly or something just to help keep it from drying out. And we got fractures of the nose. If no displacement, you may not have to do anything. Displacement of bone or cartilage can cause an airway obstruction. It can cause a deformity, cosmetic deformity. The actor Owen Wilson, he's got that funky nose. His nose kind of has a little crook to it, and that was from a broken nose, a fractured nose. And I can't remember how he got it, but you would think with all his money he'd go have it fixed, but apparently he considers it to be a defining feature or defining characteristic of him, so he hasn't wanted to get it fixed. A deviation, sometimes some people have a deviated septum, and actually they'll need to go and have surgery, which is basically fracturing the nose and having that corrected. Postoperative care after a rhinoplasty. Rhinoplasty would be a nose job, and again, that could be just cosmetic or it could be to repair a deviated septum. You want to keep the person in a semi-Fowler position. Why? Why do you think? If you said for drainage, you would be correct. Put some cool compresses on their nose, eyes, face. That helps reduce swelling. Give them soft foods. Limited Valsalva movement. What is that? It's like bearing down, isn't it? Like bearing down from like having a bowel movement. You don't want them to be putting any kind of stress on that. They'll want to have a humidifier to help keep everything moist. We got facial trauma. Always, always, always. Airway is always a priority. That's almost always the answer when you have priority questions. It's almost always airway, respiratory, breathing. Because guess what, guys? If you're not breathing, nothing else matters. You want to look for the airway assessment. That's where you look for stridor or shortness of breath, any anxiety, restlessness. When people are not getting enough oxygen, they become very restless. Cyanosis. Obviously, if they're turning blue, their lips are turning blue, their fingernails are turning blue, that's not a good sign. This is a specific type of fracture. It's a fracture of the maxillae. It's the nasoethmoid complex fracture and the maxillary and nasoethmoid complex fracture. Ooh, that looks rough. Or you could have a combination of the two. Again, airway. You want to look for their vision and eye movement. You always want to check behind their ears. Here's the maintaining the airway is first thing. Again, controlling hemorrhage, stabilizing jaw fracture, may need surgery. Laryngeal trauma. This could be from a direct blow injury or even prolonged intubation. Again, maintain that patent airway. Cancer of the nose and sinuses. My mom had cancer of the nose. It was actually a type of skin cancer, but it was up in her nose, and it was basically a sore in her nose that wouldn't heal. And she kept messing with it. And of course, I kept saying, well, you know, get your finger out of your nose, maybe it'll heal. But unfortunately, she had to go to like 3 different ENT doctors before it was diagnosed. Most of them were just kind of blew her off. Finally, the 4th one did a biopsy and found out it was cancer. So she did have radiation and had it taken care of. That's been a good long time ago. A lot of times it's caused by exposure to different chemicals. Could be cigarette smoke, could be dust. It's a very slow onset. Surgical removal, and that was an option, but they said it would be very disfiguring, so she went with radiation therapy. Head and neck cancer typically is squamous cell carcinoma. It's very slow growing. Often it's mucosa that's chronically irritated. That was what hers was. It was, you know, mucosa, and her nasal mucosa that was constantly irritated. Causes: tobacco, alcohol use, voice abuse, chronic laryngitis, exposure to chemicals, poor oral hygiene, long-term GERD, oral infection with HPV. You think about things like long-term GERD. Anytime you have a constant irritation, when things are irritated, like you think about GERD, and it's constantly causing irritation to that esophageal area. When you have irritation, your body is constantly rebuilding cells, and those cells are being regenerated to repair. Well, cancer is just a normal cell that has mutated and kind of gone astray. And so if you have that regeneration of cells that's more often than normal, you're going to be at a higher risk of developing cancer. When you're assessing someone, you do always want to ask them about smoking and their alcohol use, any lumps in their neck, if they've had any hoarseness or any change of their voice, mouth sores or lumps. Imaging, you do x-rays or CT, MRI. You can do radiation or chemo. Why would you do different? Radiation is more specific to that area. Chemo is systemic. That means if it has spread and it's in the lymph nodes and it's gone through the body, you have to do chemotherapy. Radiation is, and now even proton therapy kind of goes along with radiation. It's very specific to one area. It's not systemic. Or even a surgical intervention, have it removed. Post-op, manage your airway, manage your wound, manage pain. Nutrition, part of healing. When you have a wound, get that protein on board, right? Promotes healing. Laryngectomy. Again, I love airway right here on the top again. Always watch after surgery for hemorrhage. Anything post-surgical, you want to watch for infection, pain management, nutrition. Now with laryngectomy, speech and language rehab. You have your larynx removed. Guess what? You're not going to be able to speak. So you have to have a prosthesis to help you speak. This shows a tracheoesophageal prosthesis. and that's when they talk like a computer almost. And then basically always want to make sure you educate your patient. Okay, that was it for this particular section. As always, any questions, let me know. Thank you.